Welcome to The Explainer. Today, we're stepping directly into the shoes of a cellular sleuth. By the time we're done here, you're going to know exactly how to look at a peripheral blood smear and deduce what's actually happening inside a patient's body. We'll figure out if it's a raging infection, a hidden genetic anomaly, or just a lab artifact. Let's get to work. Here's our syllabus for this investigation. Section 1, reactive changes and organisms. Section 2, neutrophil defects and anomalies. Section 3, decoding WBC counts and shifts. And finally, Section 4, the capstone buzzword challenge.
Okay, Section 1, reactive changes in organisms. Let's dive right in and examine how normal white blood cells react to severe external threats. So, when the body is under attack, its defense system doesn't just sit there, right? It literally transforms. Think of reactive neutrophil changes as the body's SWAT team dramatically gearing up for battle against an invading organism. These aren't subtle, invisible shifts. They're distinct morphological alterations you can clearly spot under the microscope, usually triggered by severe infection or inflammation. Now, notice how these specific inclusions appear. Look right at the edge of the cytoplasm in these neutrophils. See those small, pale, light blue oval inclusions? Those are Dole bodies. They're actually RNA aggregates left over from the rough endoplasmic reticulum. When you spot these, your detective brain should immediately suspect a severe infection, burns, or even cancer. And, they usually don't show up alone.
That brings us to our next major clue, toxic granulation. Take a look at how the granules here are strikingly enlarged, noticeably darker, and peroxidase positive. What you're looking at are primary granules that have retained their prominent staining characteristics, basically because the cell was rushed out of the bone marrow in a panic to fight an infection. You'll almost always see these alongside those Dole bodies and a shift to the left. Let's gather a few more clues from the scene. If you find clear, unstained vacuoles, or worse, actual intracellular bacteria or yeast inside those neutrophils, you're looking at septicemia, a massive, whole-body inflammatory response. But wait, what if you see a neutrophil with more than 5 nuclear lobes? Well, that hypersegmentation points your investigation away from acute infection and straight toward a B12 deficiency or megaloblastic anemia. We also have to keep an eye on the lymphocytes. A reactive lymphocyte, sometimes called a Turk or Downy cell, gets really large and agranular with abundant pale blue cytoplasm. A great mnemonic here is the Crayola outline. Because the cytoplasm is soft, it gets indented by the surrounding red blood cells, looking almost like it was colored in with a crayon. Keep in mind, reactive lymphocytes have a highly variable morphology, whereas malignant cells are rigidly uniform. All right, moving to Section 2, neutrophil defects and anomalies. Let's see what happens when the suspects are genetic. Our first genetic suspect is Chidiac-Higashi syndrome. This is a rare autosomal recessive disorder. Notice those abnormal, giant, impaired lysosomal granules? They look like they're bursting out. These cells are basically packing massive weapons that are completely defective. Clinically, this tragic disorder is associated with partial albinism, central nervous system disorders, and frequent bacterial infections that usually sadly lead to death in early childhood. Contrast that with chronic granulomatous disease. This one is typically an X-linked recessive trait, meaning it predominantly affects boys. Here, the phagocytes have an NPDH oxidase mutation, so they can swallow the bacteria just fine, but because they can't generate peroxide or superoxide, they literally can't kill the invaders. The body's desperate workaround? It just builds walls around the infection, forming those severe granulomas. Now, not all genetic suspects are villains. Enter the Pelger-Huet anomaly. Look at those highly distinctive bilobed nuclei. They mimic the shape of old-fashioned eyeglasses. Just remember the mnemonic pince-nez equals pinch nose. This is a completely benign, inherited familial anomaly. But here's the catch. To an untrained eye, it violently mimics a serious left shift. So this brings us to your absolute golden rule as an investigator. Are you ready? When in doubt, check the WBC count. An inherited anomaly like Pelger-Huet is totally benign and will present with a perfectly normal white blood cell count. A real, terrifying infection will present with an elevated WBC count. The math never lies, folks. Which is a perfect segue into Section 3, decoding WBC counts and shifts. Let's crunch some numbers. You'll constantly hear the phrase shift to the left. A true shift to the left means your patient's body is frantically pumping out immature white blood cells to fight a war. But there is a strict rule here. This includes only bands, metamyelocytes, and myelocytes.
There should be absolutely zero blasts or promyelocytes. If you see blasts, you're no longer dealing with a benign leukemoid reaction, you are looking at leukemia.
Now, what's absolutely crucial is translating relative percentages into concrete evidence. A relative percentage alone doesn't give you the whole story. You have to multiply the total WBC count by that percentage to get the absolute cell count. So a total WBC of 7.0 times 70% gives us 4,900 per microliter. That is the actual hard number of troops on the ground.
And this specific number brilliantly illustrates the clinical stakes. When you calculate the absolute neutrophil count, that's combining your segmented neutrophils and your bands, and that number drops below 500 per microliter, you've hit critical neutropenia. This patient essentially has zero defense against bacterial infections. It's a life-threatening emergency.
Okay, section 4, the capstone buzzword challenge. This is where you get to play detective. I'm going to give you some evidence, and I want you to shout out the diagnosis in your head. First up, you spot Auer rods sitting inside blast cells. What's the diagnosis? Think about it for a second. If you guessed acute myeloid leukemia, or AML, you absolutely nailed it. Let's try another one. You're scanning the smear and you see delicate smudge cells right alongside small mature lymphocytes. What breaks apart that easily during a smear prep? That points directly to chronic lymphocytic leukemia, or CLL. Next evidence, the red blood cells are stacked up like coins, rouleaux formation, and nearby you spot plasma cells with a coarse, eccentric nucleus, maybe a distinct Hoff zone. What's the diagnosis? This indicates multiple myeloma, which is driven by heavily increased protein in the blood. Last piece of evidence, you see platelets swarming and sticking to the outside of neutrophils, platelet satellitism. What terrible disease is this? Actually, scratch that. It's a trick question. It's just an EDTA artifact causing pseudo-thrombocytopenia. Your diagnosis is a lab error. Just redraw the blood in a citrate tube. Here is your ultimate cheat sheet summarizing these crucial smear buzzwords. Take a mental screenshot. Notice that a full granulocytic spectrum with basophilia means CML. Giant hypogranular platelets point to myelodysplastic syndromes. Acanthocytes with nucleated RBCs flag liver disease. And of course, bugs inside your neutrophils mean septicemia. Keep this framework handy. It's absolute gold for your exams. As we wrap up this explainer, I'll leave you with this. How are you going to apply this microscopic detective framework to your next unknown smear? Will you remember the Crayola outlines, the pinched nose nuclei, and most importantly, the golden rule of checking the absolute WBC count? Keep those cellular sleuth skills sharp, always trust the morphological evidence, and I'll catch you in the next explainer.